Welcome to the session called Pulse Field Ablation of PAF using Contact Force Sensing Large Footprint Focal Catheter. I'm here with our case presenter, Dr. Moussa Mansour from Massachusetts General Hospital in Boston. And I'd like to introduce our panel, Dr. Luigi Biase from New York and Dr. Dinesh Sharma from Naples. Welcome to both of you. And now I'll actually hand it over to Moussa to take us through the case.
Hi, everybody, and thank you for Dr. Nair. Thank you for inviting me, and thank you for the organizers of the RIO meeting to have me here today. This has been an amazing show of cases, one after the other, and I can only imagine how much work it took to put in this excellent educational material. You can see my disclosures here, and what I'm going to show today is a case of an Omnipulse large footprint focal PFA catheter. This catheter is investigational. So the case that I'm going to show is a part of the Omni AF IDE study, which is currently enrolling patients in the United States. And patients in this study have paroxysmal atrial fibrillation, and it is a single arm study. So we will start the video. So here's the catheter. It's a catheter is a 12 millimeter sphere. It has electrodes on the splines. It's a 10.5. It goes through a 10.5 steerable sheet, and each application is about 14 seconds from the start to finish. It's usually in a train of 12 applications on one spot. Couple of important features of this catheter is it is a force sensing catheter. So that's an important feature in my opinion because it will help improve lesion quality. It is integrated with the Carto electroanatomical mapping system. So the same catheter is used for mapping and ablation. So what we're seeing here is we briefly saw initially when the first few seconds when I started ablation in the posterior wall of around the pulmonary veins and left pulmonary veins, and I moved now anteriorly to the anterior ridge. And I think what I want to show here is how easy it is to maintain stability on this ridge. And for all of us who we did many years of ablation with focal catheters, this area is not easy to maintain stability on. And because of the shape and the size of this catheter, it is relatively easy to position it on this ridge, as you see in the electroanatomical frame in the left lower corner. And you see the arrow indicating where the force is being applied to. It's also on the right lower corner, you can see the catheter coming in and out of the field of view on ICE imaging. So each lesion, as I mentioned earlier, and you see that if you look at the recording system, you can see this artifact is when ablation lesions are being delivered. The tags that are in purple color, the density of the color includes information in it, and this is the equivalent of an ablation index. And if the color is light, it means that you need to apply more force to get to the darker color. So we aim for and the equivalent of an FTI of an ablation index of 450 on the posterior wall and 550 on the anterior wall. And what you see here is going down the ridge. If we finish the ridge between the appendage and the left superior vein, and now we're finishing up the circle, close it by ablating in the ridge between the left inferior vein and the appendage. There is irrigation with this catheter, and again, it is for sensing. It is a bipolar ablation. So ablation occurs between individual electrodes on the spine. and also it's biphasic pulse field ablation. I find the force sensing what's one important feature. You can tell by putting the catheter on the tissue, and before ablation you will get an estimate of your ablation index before you go on. So you don't need to finish the lesion and find that you are under powered, to use the term power here, uh, after you go on. So if you're inadequate with the force, you will find out before you go on that at the end of the 12 seconds, your ablation index will not be 450 or 550. And what you do in this situation, you would go and apply more force before you go in, knowing that by applying more force, you will finish your desired, or you will be able to complete your desired 450 and 550 ablation index. So what we see here is we're finishing up the left pulmonary vein circle, and soon we're gonna start going to the right pulmonary veins. As you saw throughout the day, many of many of the operators perform posterior wall ablation. Posterior wall ablation is I do it on most patients. We will not do it on this case because this case is a part of a study protocol where by protocol, the standard ablation for the procedure is just pulmonary vein isolation without any posterior wall. So what we will see today is only pulmonary vein ablation procedure. If you folks have, while the video is playing, if you have any questions, yes, of course.
Yeah, so I was going to ask you, so this is the first catheter that we've seen today that has talked about a PFA index. And can you elaborate a little bit on the index? Like what are the characteristics that bring the index? Are you getting a number? I see the number being displayed. Are you looking at a force, or is it stability, or all of it? What are the things there that are being calculated into?
Yeah, so the main component, stability is always there, and it's easy to do because it's a carto system. So if it moves out, then it will stop, and we have to reset that particular application. The main component of it are force and time. And with this catheter, you see that the force is much higher than what you aim for. I don't know if you can see it here, but the force is not unusual to see 40, 50 grams of force to get to your pulse, to get to your index. And it's the key here is that because of the large footprint of the catheter, it is safe to apply more force. So all of us, you know that you cannot get away with 50 grams, for example, with a 3.5 millimeters catheter. But here it's routinely, most of the time, your lesions could be above 30 grams or even 40 or 50 grams. And what we see here, I move to, yes.
Can I say something about this? Because I think this is very misleading for people. You explained well, but I wanted to clarify. After we publish this at your, Boston AFib Symposium 2024, we got, the best abstract award on this index. Again, people say, well, I don't use 30 grams because we say that you need about 30 grams to have a good index. And they say, oh, that's a lot of force. But I would like to clarify, as you said, that when you have a point-by-point catheter, you touch the tissue is 10 grams, already a good force. This catheter being like a flex ball, when you touch the tissue, you start at 10 grams. 10 grams is equal to 1 gram with another catheter. So 30 grams with this catheter are the equivalent of 10 grams with a point-by-point, because it's just the way it measures the force by being a flexible. So although the number 30 looks big, 30 grams of this catheter are the equivalent of 10 grams with another catheter. So 50 grams is what is 20, 25, 30 grams. So we don't want, I think it requires clarification. You said it right, but I wanted to add this.
Yeah, it's,
it's an average of all the splines, or is it? Yeah, so that's what
No,
the
the
question.
force,
It's
the
a
force.
different shape, right?
Yeah. So are you talking about the force sensors?
Yes, yes.
The force sensors, no, they are not on individual electrodes. It's the central force sensors for the whole sphere as a whole. So you don't have individual force sensing on all the electrodes. It's one force sensor at the center of the catheter. So what you see here is we finish the posterior, the right side posterior wall of the right-sided veins. I'm going anterior, going down as a septal portion of the right veins. And again, point by point, catheter is stable. If you see the catheter sometimes moves from time to time, it's probably from phrenic nerve capture, which happens with all PFA catheters. There's difference that if you capture the phrenic nerve when you ablate, doesn't mean that you're going to injure the phrenic nerve. Actually, it's almost unheard of to have permanent phrenic nerve injury with any form of PFA, but you see it being captured when you do ablations with all form of pulse field ablation catheters. So I think it's the main, one of the most important feature of the catheter is versatility. You know, to be able to map and ablate with the same catheter, I believe it's very important. And also to see it integrated with a 3D electroanatomical mapping system, in addition to the force sensing capabilities of it. So these, in my opinion, are the differentiating features, the force sensing and the integration with electroanatomical mapping. So this, we're finishing up
Dinesh,
this
let's,
last, sorry, go ahead.
No, it's
You
okay. I
said
was going to
something.
ask Dinesh. I know he's had experience with this catheter as well. You know, there's so many large footprint catheters out there for PFA now. Where do you see this? I know Moussa said it's the versatility of the platform, but where do you see this being used? I know in the trial it's a PVI only workflow, but do you see that it's going to have a different usage, or is it the PVI tool?
Yeah, I mean, as Moussa and Luigi mentioned, that it's a great catheter, very versatile, and I think it's very safe too. That's what our experience had been in a few patients we did. So as Luigi mentioned, that yeah, contact force actually you want at least 30, or you prefer at least 30 grams of force, and I have given lesions close to 90 grams. It's not a concern, and it's a PF energy. We're not giving RF. So that's really beneficial to get that feedback. Other thing is because the long lesions, you don't have to worry about stacking the lesions. You already kind of plateaued after one lesion you gave if it was stable. So that's another benefit of you can move confidently. When we are ablating, you're not second guessing yourself. I think, as Musa said, as per the trial, we have to restrict to PVI, but given the efficacy of the catheter, we submitted to Musa for AF symposium. Hopefully, he accepts it. But if the efficacy of catheter is good, I think we can probably use it in the posterior wall too. So I think it's going to be a versatile catheter in the future.
So Devi, where obviously where the field is going is seems to be gonna end with like three categories of catheters. One is a large catheter that's mainly for pulmonary vein isolation. And then you have the category in between, which we never had before the days of pulse field ablation, which is the 9 mm sphere or this catheter here, and then the small focal catheter. I think this category in the middle, I think is going to be the most versatile. And this is where, in my opinion, is going to be used in a lot of patients because it will give you the flexibility to go outside the pulmonary veins. All of us continue to use, and have used the larger catheters for non-pulmonary vein applications. Certainly the easiest is the posterior wall. We all have used the catheters for mitral isthmus, but we learned after a year or two of using it that there is a little bit of more than what we like to see, recurrence of the mitral isthmus connection. It may be okay for the CTI line, but if you have a catheter like this, you don't have to work hard to try to get contact and outside the pulmonary veins. So this will give you the benefit of quick pulmonary vein isolation, in addition to the flexibility of ablating outside the pulmonary veins.
I agree with you, Moussa.
Map with the catheter?
I think
Yes, you can
Uh,
create a map with this catheter, and as you it's easily done. But as a part of the study protocol, we had to acquire it with both with this catheter as well as with multi high density multi spline catheter to just for comparison for this study. But eventually, when this is hopefully released in the market, you can do the whole case just with one catheter.
Debbie, if I can add something, I mean, I agree with Moussa. I think the beauty of this is that companies are giving us options, and while maintaining cost, we will have options that we didn't have before. So before we had point by point, we had to do everything with a point by point calendar. Now we can go for what each of us like the most. Personally, I think that there is a difference between a first procedure and a redo. When you have a first procedure that is a fib, and you have to do PVI, and if you believe PVI, posterior wall, and SVC, I feel a so-called single shot or multiple shot catheter to me has the advantage of eliminating the stability component of the procedure. When you have to do a redo, there's no way that if you have this catheter in your hand, you use a solution like this, because you map, you find the gap, you can complete everything you want. On the other hand, Moussa may say, I use the solution like this for everything. I feel after using PFA without the catheter stability in my mind, and with the beauty of not this being like RIO, but being, I can go antral, I can do posterior wall with a single shot. I prefer that solution for procedure, but it's what I like. It's not because it's good like that.
It's a great point. I guess the other question I have is anesthesia. I know majority of the cases in the U.S. are with general anesthesia, but now with the ASCs popping up and the talks about ASCs, and of course for our counterparts in Europe, what are your thoughts about the use of this catheter with lighter forms of sedation, propofol for our European counterparts? Where do you see this going? Is it possible?
Yeah, it's I mean, it's possible. I believe it's not going to be as good as doing cases with general anesthesia, because the catheter will jump when you get skeletal muscle stimulation, and I think eventually it may affect the efficacy. And obviously, it's going to take, it may not be, this is only a gut feeling. I don't think you can prove it to get a study to show a superiority with general anesthesia compared to conscious sedation. You're going to need a large number of patients. But I don't think personally I would use this catheter without general anesthesia. I mean, we're not using conscious sedation for anything now. And certainly if we change, it will be probably only for large catheters where the amount of movement because of skeletal muscle stimulation is less. So if you have a large circular catheter like the one that Luigi showed earlier, or an over-the-wire pentaspline catheter, if you push it against the tissue, the chance of it moving is less than when you have this focal catheter.
Dinesh, I'm going to ask you a question, a little provocative here. You've had your hands on dual energy medium footprint catheters, and we've seen some usage of that catheter through the symposium today. And now you have medium footprint catheter that's PF only. How do you put them side by side? I mean, do you see there is a value in having one or the other, or do you see that there's no reason to have dual?
Well, I think there's definitely a benefit having a dual energy. In this trial, let's say if we had to do a CTI ablation, we would get a Q dot catheter out. So it is, we know it's efficacious to do RF on CTI, and it's safe. It's we have done thousands of procedures with RF. With PF, there's published data with nitroglycerin, but it does ethically challenges me. I find it difficult. to put patients hypertension, but hypotension. It just I'm not comfortable with that, but I've done it. So I personally think it is nice to have dual energy, especially if you're doing a mitral isthmus line, you know. But if you want to use PF only, especially with this catheter, I think we need to do as a research protocol. We should avoid using as off-label because we don't know efficacy, but we definitely know the risk. So I think more research needs to be done. But going back to this catheter, I think we can use it for most of the procedures, like which we do PVI, posterior wall, or away from the coronary arteries. I think it should work.
Yeah, I mean, I look at come back to what Moussa said. It's going to come down to the three family of catheters. I mean, in areas, say like the CS and the smaller, smaller areas, I think we're going to go to the focal catheters. And I mean, today, I dread having an SVT during an AFib case because I 100% know I'm going to have to pull out a single tip catheter, which is just not cost efficacious anymore. It's just not possible. I don't know. I mean, do you think? Go ahead, Luigi. You were going to say.
No, I mean, I like analogy all the time. I use this with my patient. I feel like we have an analogy with cars here. There are cars that are gas only, which is the RF, and there are electric cars, which is PF. But we know that they are not ready yet to complete the job, and we have hybrid cars. And today, I think people say, man, maybe a hybrid because I don't know. Sometimes I may need to go to drive far longer, or I don't know if I have a charge. But eventually, I think electric cars will replace gas cars, and I think eventually PF will completely replace RF. But today, for mitral isthmus, for a few areas where you need the more deep, you need some RF today. Will RF replace PF? I think at some point you will. But today, I think the hybrid solution, it's necessary if you want to have one tool that can do everything.
So, Moussa,
I mean, the issue
question about. Go ahead.
Go ahead, please.
No. Go ahead.
So
you were going to say something.
Pulse field versus NRF just versus pulse field alone. There are two aspects to take into account to decide whether or not you need one or both. One of them is complications, meaning when you're near a coronary artery, whether switching to RF makes it easier. And the second one is that lesion depth. I think the need to have a hybrid catheter is, in my opinion, is not critical, because when you come, for example, to the proximity to the coronary arteries, you can easily prevent it by giving nitroglycerin. Yes, it is one step more, but I think it is easily done and preventable. When it comes to lesion depth, I'm not sure that within even now, and certainly more in the future, I really doubt that pulse field energy will have less depth of the lesion compared to RF. If anything, it will probably be more, knowing that you can deliver more lesion on top of each other, stacking, which could be more of a problem with RF rather than pulse field ablation.
I'm going to ask a final question and any one of you can take it that can give me an answer. Can you talk a little bit about the lesion depth with this catheter, and if there's any thoughts on taking this catheter to the ventricle at any point?
So I will talk a little bit about it, and then I think Luigi have done some work on the preclinical arena and also in defining the index. I think you can get with this catheter, you probably get around 5 to 7 millimeters, maybe 5-6 millimeters lesions, which in my opinion is adequate for the atrium. I don't think at the current version we have, it is enough for the ventricle.
In the animal work I did with Hiroshi, yes, I think this catheter is set for a 6 millimeter depth. Maybe in some specific, with some specific force, can get to 6.5. So I think it's adequate from the atrium. Not ready yet for the ventricle at this time. They're working on the sequence 2 of the fast protocol, and probably they're changing the wavefront in a way that could reach deeper. So I think it will be in future a good tool, but right now I think it's adequate from the atrium and not for the ventricle.
All right. Well,
Seen-
on that note, I think we are getting close to the end of the session. So thank you, Moussa, for such a great case and going through the workflow. And thank you, Luigi and Dinesh, for sticking around and sharing your thoughts. The next session of RIO 2025 US Focus is coming right up.